Kako povezovati elemente med sabo, se sprašuje tudi v mnogih drugih državah. In zdajle se nam bo kmalu pridružila kolegica Marina Maggini iz Italijanskega inštituta za zdravje, se pravi ne za javno zdravje, ampak za zdravje. Ona je zelo aktivna tudi na mednarodnem področju v že imenovanem projektu CRORIS o kroničnih boleznih, ker Italija je naredila eno vajo o tem, kako zdaj pa povezati primarno raven pa sekundarno raven, skratka specialistično raven. Italija je majčkeno bolj specifična, kot Slovenija, zato ker je toliko veliko ljudi na kupu, je zadeva na regijskem nivoju organizirana, tako da, ko bo ona govorila o regijah, je to tako, kot pri nas velja seveda za celo državo. In ponovno zato, da bomo lahko se razumeli, bomo imeli prezentacijo hkrati v slovenščini, ja, gospod kima, da ja. Tako da bom zdaj jaz pozdravila Marino. Marina, can you hear us?
Yes, I can hear you. And you?
Yes, it's perfect. Here is the audience, again, a good mixture of audience with a lot of representation from patients and other professional groups. We also have here representatives from the ministries, including Ministry of Education. So we are really looking forward for next ways to integrate cross-sectorially. To je investicija v prihodnost Slovenije. So I would really like to introduce you with your talk. I explained already that you in Italy already did exercise how to integrate care among the primary and secondary care. And we are really eager to find out what were your experiences, how you did that, and how successful you were. So please start with the presentation.
Thank you, Jelka. And I want also to thank all the organizer of these meetings. And I would have preferred to be there with you in your beautiful city, but as you know, unfortunately, it was not possible. So I will briefly present how and why the IGEA project was developed in Italy. It derived from the necessity to contrast the rising prevalence of chronic diseases and to assure a good quality of care for people with chronic diseases. As you know in the second slide, chronic diseases affect the persons over a long period of time and generally progress slowly, but some of them cardiovascular diseases, cancer, chronic respiratory diseases, diabetes, and also mental illness are becoming the leading causes of morbidity and mortality and account for about more than 80% of deaths in Europe. They affect almost 8 out of 10 of people aged over 65 in Europe. But the majority of chronic diseases can be prevented. Tackling for major risk behaviors, smoking, alcohol abuse, unhealthy diet, and lifestyle can help prevent many chronic diseases. To efficiently address the challenge of chronic diseases, an integrated horizontal approach is essential, involving all the relevant levels from communities to policymakers. In the slide 3, we have some sentences explaining how the situation is evolving in these years. In fact, on the world, people are healthier, wealthier, and live longer today. But the nature of health problems is changing. Healthy life years may be not increasing in line with life expectancy. Along with demographic change and population aging, the burden of chronic diseases increases. Individuals present with complex symptoms and multiple illnesses, and substantial progress in health is deeply unequal. Many health systems, unfortunately, are still largely built around an acute episodic model of care. And decision makers, policy makers, and leaders in health are facing the challenge to redesign healthcare systems to better meet the complex needs of persons with chronic diseases like diabetes. First Persons with chronic diseases require not only effective treatment, but also continuity of care and adequate information and support so that they can achieve self-management to the greatest possible extent. Then we need to reshape our healthcare systems to facilitate the transition from fragmentation to integration of care, including prevention efforts and incorporating community resources in order to ensure a seamless care coordinated with and around the needs of people with chronic diseases. In the slide 6, we have some of the statement of WHO in the document published in 2005, Preventive Chronic Diseases, a Vital Investment. In this document, WHO indicated that comprehensive and integrated actions is the means to prevent and control chronic diseases. The essential elements being evidence-based decision support tools to improve the delivery of effective care for chronic diseases, the development and implementation of evidence-based treatment guidelines, that is fundamental to putting evidence into practice, effective clinical information systems, including patient registries, are an essential tool for providing the continuity of care necessary for chronic diseases. A multidisciplinary healthcare teams that can be highly effective approach to improving chronic disease care. And it is necessary to support patient self-management because this is a core element of effective chronic disease care. This awareness led the Ministry of Health almost 10 years ago, more than 10 years ago, to make a serious commitment to fighting diabetes and chronic diseases through the activities of the National Health Service. In particular, the complications of diabetes were included among the priority areas of intervention in the National Prevention Plan through the adoption of chronic disease management programs. Moreover, in 2006, Italy, together with other countries of the Regional Office Europe of the WHO, approved a comprehensive strategy for fighting non-communicable diseases known as Gaining Health. This strategy focuses on reorienting healthcare service toward developing primary care and increasing the self-management of persons with chronic diseases. Within the National Prevention Plan, the Ministry of Health and the National Institute of Health developed the IGEA project, which defined a comprehensive strategy for implementing a chronic disease management intervention in Italy. The overall objective of IGEA was to improve the quality of care for people with diabetes, placing the person at the center of the organization of care through the development of an organizational model that guarantees effective intervention for all persons with diabetes, implements evidence-based interventions, ensures that both the quality of care and improvements in outcome can be measured, and promotes the partnership between primary and secondary care in multidisciplinary healthcare teams. Moreover, it ensures also that the care model can be gradually implemented in the entire country, taking into account regional health organization as well as local needs and capabilities. The project defined the national strategy, leaving to the regions the local implementation and adaptation. All the phases of the project were conducted in close collaboration with regional health authorities, with health professionals and representatives of patients. And I feel that this collaboration among all these actors was one of the key points for the success of the strategy. As part of the IGEA project, we have produced a series of tools to support the regional health authorities toward the implementation of disease management for people with diabetes. the development of guidelines for managing type 2 diabetes in adults. I will give you some others information in the subsequent slide. The development of information systems that are sustainable and that encourage communication not only among physicians but also between physicians and patients, so to achieve long-term coordinated care. The training manual, a tool aimed to help professionals to promote multidisciplinary healthcare teams as an effective means of achieving the goal of improving healthcare outcomes. And the definition of care pathways for diabetes to link evidence to practice. The care pathways translate the recommendations into processes and time frames for the management of the disease. I'd like to share with you some more information on the guidelines because I feel that it was the most important document produced by the IGEA project. The document provides the minimum clinical and organizational requirements for the integrated management of diabetes and a series of recommendations to improve the quality of care, defining who does what and when, and defining also a series of indicators to monitor the project and the quality of care, of course, for people with diabetes. A multidisciplinary working group was selected by our institute, and this working group formally defined the priority aspects of care for persons with diabetes and produced the recommendations based on systematic reviews of the literature. The recommendations were developed using the GRADE methods. The document contains information and recommendations which, based on the model of disease management, are aimed towards improving the quality of care of persons with diabetes. And it is also intended not only for health professionals, but also for patients and decision makers. And last but not least, IGEA was an integral part of the National Diabetes Plan. The plan was delivered in 2012, and it has defined the strategic approach and the common objectives and recommendations for the Italian regions toward high quality of care for people with diabetes. So, thank you for your attention.
Thank you, Marina. So you already mentioned the critical point. As I understand, it was the one that made people talk together. How you did the training for the professionals and others that are involved in the IGEA project? Maybe can you explain that in a word or two?
Yeah, we decided to involve all the regions, all the Italian regions, in this task, and so we organized we organized a training for people coming from all the regions, putting together different professionals, so specialists, general practitioners, dietitians, nurses, and patients. And this was the means to teach to all the people to work together. Then we made a sort of cascade training, so each group of people coming from specific regions then organized other meetings in their regions following the same methods. And it was really successful.
Thank you. I'll explain that briefly in Slovenian. Torej, jaz sem zato, ker malo bolj poznam projekt od blizu, vprašala, kako pa ste naredili, da so se vsi ti ljudje pa zdravstveni strokovnjaki začeli pogovarjati med sabo. Je rekla tako, dobili smo jih na kup in jih nismo spustili, dokler se niso pogovarjali med sabo. In šele, ko so, se pravi, najprej na nivoju države, pa so šli ti po regijah, tako kot mi rekli, da grejo zdaj po teh, recimo, 8 regijah Slovenije, in so tudi tam pač enostavno dobili na en kup zdravnike raznih strok, diplomirane medicinske sestre, druge, vključno tudi bolnike in so se zato, ker so sedeli skupaj, enostavno začeli pogovarjati in dogovarjati. In to je bil ključen moment v tem, da je ta IGEA projekt v resnici zaživel. To se mi je zdelo tako pomembna točka, da sem si jaz držala postaviti tudi to vprašanje, ne da bi vam ponudila to priložnost. Zdaj pa časa je dovolj, ker ne skrbite, domov bomo šli 14:30. Čas je za vprašanje 2-3. Izvolite.
Jaz bi pa vprašala, če bi lahko nam bilo razloženo majhen več ali pa bolj konkretno o finančnih spodbudah za to, da ljudje izvajajo integrirano oskrbo. Kje se da za finančno spodbudo intervenirati, da se v praksi potem dejansko to zgodi?
Marina, this is a question to you from Vesna Petrič from the Ministry of Health. She is asking about the financial incentives that actually support or facilitate the actual implementation of integrated care. Can you maybe elaborate a bit on this, please?
Yeah. It depends on the regions. So we don't have national incentives, but each region can decide if use some of the budget that they have for this kind of activity to facilitate the implementation. Some regions used to give incentives to general practitioners, while for specialists and other health professionals, usually they didn't use any incentive, because this change of the model of care was part of the regional program, health program.
Se pravi, čisto na kratko, Italija je regionalizirana tudi glede financiranja in vsaka regija zase se je odločila, na kakšen način bo za finančnimi vzpodbudami pomagala pri implementaciji tega projekta. Nekatere regije so imele finančne, se pravi, so bile finančne vzpodbude namenjene splošnim zdravnikom, tam nimajo družinske medicine, ampak družinskim zdravnikom, dočim vzpodbuda za delovanje timov na specialističnem nivoju, finančne pa niso bile potrebne, zato ker je bil že plan zdravstvene oskrbe posamezne regije, je že inkorporiral ta spremenjen način dela v posamezni regiji. Another question from the family medicine specialist, a young guy, here for you.
Yes, Mike, slovenščini verjetno.
Ja, prosim.
Mene pa zanima, kako ste se znajdli, kdo je pravzaprav koga učil? Zelo pogosto prijemo do te težave, da reče družin, se jaz vem, kaj delam, jaz delujem v drugem okolju, to ni bolnica, jaz bom to po svoje naredil, bolničnični doktor reče, ne, to mora biti tako pa tako pa tako. Kdo je koga učil? A so vse učili ali kje je prišel kompromis?
So the question from the family medicine specialist, who was actually training whom? Because the GPs say we know what we have to do, we know our patients and our society best, and on the other hand, specialists say, no, we know what are the guidelines, how it should be done, so you should listen to me. How you did that in Italy?
Yes, in Italy it is exactly the same, and it was really difficult to put together all the specialists, in particular general practitioners and specialists, and also specialists and nurses. So the idea is to have this training made, putting all people together, but also asking to nurses, dietitian and general practitioners and specialists to give the lessons. So the most important thing for them was to accept to work together. But you know, in Italy we are partly in a good situation because we had from 20 years diabetic centers in which already specialists, nurses, dietitians are used to work together. So the most important challenge was to include also the general practitioners. You know, it's not yet completely solved, but now they are starting to learn to work together.
Thank you. Torej, tudi v Italiji so problemi popolnoma enaki. Dejansko je bila stvar tega, ki je organiziral izobraževanje, stvar njegove modrosti, kako je sestavil program na tak način, da so dobili vsi svojo besedo. Da je vsak povedal svojega vidika. Skratka, ni ključno to, da se vsi strinjajo, kaj je treba povedati, ampak da se vsi strinjajo, da bodo to povedali na istem dogodku. In tako se je začela. In dejansko so bile najboljše prakse iz sodelovanja med zdravnikom in medicinsko sestro iz diabetoloških centrov, ki pač so v Italiji v preteklosti obstajali, kjer je pa dobra izkušnja dela zdravnika in medicinske sestre, hkrati v bolniku bila tudi neka vzpodbuda drugim zdravnikom, ki do zdaj v praksi še niso sodelovali z medicinskimi sestrami, da je to res nekaj koristnega. Skratka, dobiti ljudi skupaj in da skupaj pripravijo izobraževanje, na tak način so se tega lotili v Italiji. Še tretje vprašanje? Marina, we don't have the third question for you. Or actually, I did the first one already. So we had 3 important questions. Thank you again for your communication with us and sharing us the problems also that you are facing and the solutions that you had. And we are really happy that we can work also in the future together, sharing good practices.
Okay, thank you. Thank you, Jelka, for giving me this opportunity.
Thank you.
Thank you.